Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Greetings to you. My name is Babafemi Taiwo. I'm the Chief of Infectious Diseases at Northwestern University in Chicago. And today we're going to be taking the first of 4 clinical clips taken from the conference on Retroviruses and Opportunistic infections that is going on in Seattle as we speak. Today I'm going to talk about 4 of the presentations that we received today, starting with one that had to do with doxycycline for post-exposure prophylaxis among cisgender women. This study was performed in Kenya and involved, and this was actually the first study looking at this potential intervention in cisgender women. The study enrolled women who were on PrEP already and who were non-pregnant and randomized them to 2 arms. One of the arms received STI post-exposure prophylaxis with doxycycline dosed at 200 milligrams within 72 hours of a sexual encounter, and the other really just followed standard of care. The question of interest was to see whether doxycycline for post-exposure prophylaxis was effective in preventing or reducing the incidence of sexually transmitted infections, which of course includes chlamydia, syphilis, and gonorrhea. The participants in the study were seen every 3 months for STI testing and treatment as needed. The study was well powered. And going to some of the important results, one was that at baseline, they found high rates of STI infection, totaling about 18%. And this really was driven by high rates of chlamydia infection. 80 pregnancies occurred during the study. No HIV infection occurred on study because, of course, these were patients on PrEP. But in terms of the primary goal of the study to see whether the doxycycline for post-exposure prophylaxis was effective in preventing STI incidents, it was surprising that there was actually no effect. There were 3 potential reasons raised. One was that maybe there were anatomical differences that the endocervix might have compared to the rectal area or, let's say, the urethra. That might explain this, but this is not supported by some of the other studies that we had at this meeting or that we've received at this meeting. Another possible reason that they raised was maybe adherence was a driver of this, but again, not very strong support for this because in fact, no HIV infection occurred and they were getting reminders, etc. And the final potential reason that they considered was maybe resistance was an issue, but again, this did not, probably did not fully explain what was observed, because we know that there is no known resistance to chlamydia, of chlamydia to doxycycline. And so one would have expected some efficacy from chlamydia or against chlamydia. So overall, unexpected results and more to come. Another study still on the issue of doxycycline for post-exposure prophylaxis sought to understand the potential impact of using this intervention in the population in which it had shown efficacy. So now talking about bisexual, gay or bisexual men and transgender women, and a very small number of individuals who were non-binary individuals. And to answer this question, the investigators from Feinberg Health looked at a lot of individuals and randomized and looked at them in 2 categories and tried to do some modeling. The main question here was to say, well, if we actually do have doxycycline post-exposure prophylaxis available, what are the prescribing patterns or strategies that will give us the greatest benefit from a sort of a implementation approach? The main finding of the investigator from this investigation was that the strategy that appeared to be most efficient was one in which evidence of prior STI was required before prescribing the doxycycline for post-exposure prophylaxis. And in that context, it was given for 12 months. That really seemed to be the most effective way. In fact, they reported about 42% of potential STIs will be averted if that sort of approach was implemented, specifically an approach in which individuals were given the post-exposure prophylaxis if they've had an history of STI before. And then going further, there was another study that looked at mortality, which we know, of course, is an issue globally, of course, a lot of gains have been made. And right now, the question was answered using the RESPOND cohort, which is in Europe and Australia. This RESPOND cohort included over 33,000 individuals, average follow-up period of 5 years. And they provided some real key information in their results. One was that all-cause mortality was on the decline, which is welcome and, of course, somewhat expected. And that there was an increase in the average age or the median age at mortality from 52 to 56 years. Again, good, but not perfect, knowing that life expectancy is much higher than that. But drilling down, they also found that looking at the specific causes of or the drivers of mortality were actually non-AIDS malignancies. And when looking at the risk factors for mortality, they identified modifiable risk factors. So the key is that there are still modifiable risk factors that we can, as clinicians, work on. So a lot of some improvement, but room for us to improve clinically. And finally, a study sought to understand which factors drove providers to prescribe big TAF FTC versus dolutegravir 3TC in the switch context. And this study used data from the Taiwo Health Network and came up with some interesting findings after looking at about almost 6,000 people that switched to big TAF FTC and about 1,000 who switched to dolutegravir 3TC. They found after the analysis that the persons who were switched to big TAF FTC tended to be people who had more complex history or more complex HIV context, such as low CD4 count or substance use, whereas the people who were switched to dolutegravir 3TC tended to be those who had other sort of different issues, such as renal insufficiency, or patients who had been exposed to integrase inhibitors before, or patients who were obese. So clinicians seem to be differentiating which patient they give or switch to big TAF FTC compared to patients who they switch to dolutegravir 3TC, which overall, I think it's good for the field because it again speaks to the idea that patient treatment should be individualized. Having covered those 4 cases or 4 presentations today, I'd like to thank you for joining us on this day 1. I invite you to check the landing page for additional information which you can get through some of the slides, and of course come back tomorrow to join us for day 2 of the 4-capsule clinical series. Thank you.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.